بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أكرم المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is almost the last lecture in the sector of the chest imaging, and as I have said before, this will be about the imaging of the chest wall lesions. And I have finished the lecture before talking about the pleural lesions, and this is the second part of this topic, which deals actually with the pleural and chest wall lesions together. Then the chest wall is composed of the ribs, as you all know, some of the muscles, other soft tissues, the breast, as well as the diaphragm. Actually, lesions of the diaphragm will not be discussed here, and I hope I can cover this part in the abdominal imaging sector. Then we'll deal with the chest wall disorders from these points of view. Number one, the congenital and developmental anomalies. Number two, the inflammatory and the infectious diseases. Number three, the neoplasms. And number four, the traumatic lesions. Then the congenital and developmental anomalies include one of the common lesions, the cervical rib, the cleidocranial dysostosis, the Bullen syndrome, victus excavatum, and the pigeon chest. The cervical rib, as you all know, is a supernumerary rib which is attached to the last cervical vertebra, and this rib may be cartilaginous, not seen in the plain X-ray, may be bony and of variable size and configuration. And this rib may be like this, or may articulate or form a pseudo joint or pseudo articulation with the posterior part of the first rib. And this accessory rib may be symmetric, bilateral, maybe unilateral, maybe asymmetric. One rib is small and another one is relatively large. And this anomaly represents about occurs in about 0.5% of the population, and in about 90% of cases, cervical ribs are asymptomatic. And the symptoms are, of course, the sequelae of compression, especially of the brachial plexus and the vessels crossing this part of the thoracic inlet. Then, in order to be sure that this is the cervical rib, you look to the transverse process of the vertebra where the rib is attached. And you know that the transverse process of the first dorsal vertebrae and all the dorsal vertebrae is facing relatively upward, while the transverse process of the seventh cervical vertebra is almost horizontal or even relatively facing more down. Then if the first dorsal vertebrae, if you see the transverse process is facing relatively up, then this is the first rib, and this is the transverse process which is almost horizontal, and this is the accessory cervical rib. Then, as I have said, the cervical rib may be unilateral, may be bilateral, may be symmetric, may be asymmetric, and in my opinion, the best diagnostic imaging modality is just the plain X-ray, the frontal view of the cervical spine or the cervico-dorsal region. Then we came to the victus excavatum, which is also known as the breast sternum, where there is depression of the sternum compressing the cardiac shadow, and the heart will be displaced into the left hemithorax, and this will result in this configuration in the frontal view. When you look to the frontal view, you should see some of the cardiac shadow to the right side of the spine. But in cases of the breast sternum and the heart is almost totally displaced on the left, in the left hemithorax, you cannot see part of the heart to the right side of the spine. Then if you look to the lateral view, and you can see the degree of external depression. And this can be easily identified clinically on the patient, where you can see this very marked depression of the sternum on the anterior chest wall. And this, of course, the sign where you look to the chest x-ray and you realize that the patient is well centralized by measuring the distance from the spinous process of the dorsal vertebra to the medial edge of the clavicle on the left and on the right. These distances should be equal. Then you know that the patient is not rotated. And in such a case, whenever you cannot see part of the heart to the right side of the spine, and you may guess that the patient may have a depression of the sternum, and you can look to the lateral view. Then with the use of the recent imaging modalities and the multi-detector CT, you can have this 2D reconstruction, and also you can have this 3D reconstruction demonstrating this abnormality carefully. And the opposite of the breast sternum is the pigeonhole chest, or the pectus craniatum, where the sternum is not depressed. Instead, it is seen bulging anteriorly. And this will not appear in the frontal view because it will not affect the cardiac shadow, and is clearly identified in the lateral view. Then pectus craniatum means that there is deformity in the chest in which the sternum exhibit abnormal protrusion anteriorly, and this anomaly is frequently seen in patients with cyanotic congenital heart disease. As I have said, the anomaly is easily appreciated in the lateral view, and of course in the CT scan as well. And cleidocranial dysostosis is one of the dysplasias which are associated with almost total absence of the clavicle on both sides. And this is one of the common x-rays in the exam. And you look carefully to the chest, you find nothing, and the lungs are normal, costophrenic angles are clear, normal cardiac size and shape, but you hardly appreciate that the clavicles are absent, and this is one of the tricks usually used in the exams. And most of this syndrome will be discussed with the skeletal dysplasias later on. Then Boland syndrome means that there is partial or total absence of the pectoralis major muscle with ipsilateral syndactyly. Then whenever the pectoralis major, as you can see here in the CT section, this is the pectoralis major and this is the minor, and both are absent here. Then absence of the chest wall muscles will result in appreciable radiolucency of the ipsilateral hemithorax. And this radiolucency or hypertranslucency can be caused by too many other lesions, like removal of the breast in cases of mastectomy, and unilateral emphysema in cases of McLeod syndrome, for example, and too many other pathologies. But in this case, it is the absence of the pectoralis major muscle which will result in this hypertranslucency on the hemithorax. And commonly associated anomalies include atrophy or absence of the ipsilateral ribs from the second to the fifth one. Very common, you can see that these ribs are hypoplastic or even not present. Absence of the pectoralis minor muscle, which is this one, as you can see here, both muscles are absent. Aplasia of the ipsilateral breast or nipple. Then here you can see the hypertranslucency on the left side. The CT scan showed absence of both pectoralis major and minor muscle. And you look also to the absent ribs, like these are the normal ribs, and the hypoplasia of the more posterior ribs. Then inflammatory changes, like any other part of the body, will include the biogenic infections, TB, actinomycosis, aspergillosis, and any other organism. It will result in cellulitis and abscess formation, and this may be associated with osteomyelitis of the adjacent ribs or sternum. And the role of imaging, in my opinion, is to assess the intrathoracic extension of such lesions, where if the lesion is totally outside the chest, the management is almost easy, while intrathoracic extension may need more sophisticated techniques for management. Then this is the diabetic patient with fever and parasternal swelling, and the CT scan showed that the sternum is almost totally eroded and is surrounded by a soft tissue mass of heterogeneous density and enhancement, together with the presence of air loculi and a stranding or smudging of the adjacent fat planes, denoting the presence of an inflammatory process here. And of course, you cannot predict the causative organism from the scan, but actually, whenever you have samples from the inflamed tissue, you can reach the diagnosis. You remember that I have said before the relationship between TB and calcium. And I have also emphasized the importance of enhancement of the edge of the pleural collection for the diagnosis of empyema. And whenever you see calcium, you may suspect the underlying tuberculous etiology, but you should remember that calcium can also be seen in other forms of empyemas in the chest or even in the chest wall itself. Then empyema, as you remember, can also extend through the intercostal spaces into the adjacent subcutaneous tissues, as well as into the chest wall, forming a collection, and then this time this empyema will be known as the empyema necessitans. Then this is a classic appearance of a chest wall abscess, a hypodense fluid collection with uniform marginal enhancement and reticulations or stranding of the adjacent fat planes. The scan showed no evidence of intrathoracic extension. And this is also a classic appearance of a multilocular chest wall abscess seen here. And this is an internal septation. You can see air loculi, and you can see the thick enhancing margin and the fluid content. As I have said, you cannot predict the nature of the lesion unless you have samples from the inflamed tissue. Then, considering the chest wall tumors, the tumors may arise from the components of the chest wall, like the muscles, the bone, the cartilage, the fat, the fibrous connective tissue, the intercostal nerves, the breast, as well as the blood and the lymphatic vessels. Then these are the soft tissue tumors, including lipoma, which is one of the common lesions seen in the clinical practice, neurogenic tumors, hemangioma, desmoid cyst, desmoid tumor, hemangiopericytoma, lymphoma, and in the soft tissue sarcomas. And this is an example of lipoma in the axilla, and you can easily appreciate the diagnosis because of the fat density, which is similar to the fat in the axilla. And whenever you measure the CT density, it will appear in negative values. Then you know that this is fat. And this is also a small chest wall lipoma with a relative bulge underneath the pleura, and it is located underneath the serratus anterior muscle. Then intercostal schwannomas are well-defined, homogeneously enhanced lesions based to the pleura or even present in the intercostal space, and you can usually not reach the final diagnosis unless you have a biopsy from the lesion to confirm the diagnosis. But an appearance like this can be also fit for a pleural-based metastatic deposit, can be also a localized form of mesothelioma, for example, And of course, the intercostal neuroma or schwannoma is one of the examples. And here you can see a lesion which is based to the or centered to the intercostal space, is smooth margin with homogeneous CT density. And as I have said, you cannot reach the diagnosis unless you have a tissue biopsy. Then this is a neurofibroma in a patient with neurofibromatosis. You see the skin and you see multiple neurofibromas on the skin. Then you see a mass which is enhancing and is located in the axilla, where the roots of the brachial plexus brachial plexus can cross here. Then you see the lesion on MRI of heterogeneous signal intensity is not of fat and is not cystic, meaning a fluid containing lesion. No, then this is a solid lesion, and together with the clinical appearance of these multiple neurofibromas, then you can easily reach the diagnosis. The hemangioma of the chest wall is also one of the well-known lesions. And hemangioma is easily diagnosed by contrast-enhanced CT, and can also be diagnosed carefully by the MRI, considering that the hemangioma will show a very bright signal on T2 weighted image, and if you inject contrast media, it will enhance significantly. The value of CT is to detect these minute lesions which represent calcified Filippoli, and these are undetectable by MRI. And this is the value and the sensitivity of CT to detect calcium over the MR scans. And here you see a hypervascular lesion which has an intrathoracic component and a diffuse chest wall involvement. And you can see the pools of contrast inside the lesion, as well as the tortuous microvascularity involving the chest wall muscles, representing the hemangioma. And as I have said, the hemangioma and the T2 weighted image will show very bright signal, as you can see here, but in the MRI T1 weighted image, it will look of intermediate or even low signal intensity, and if you inject the contrast media, it will enhance significantly. Then one of the common lesions which are clinically seen, which are seen commonly in the clinical practice, is the elastofibroma dorsi. And this is a benign lesion which is located in a very characteristic location just below the inferior angle of the scapula, between the serratus anterior and the chest wall. And this lesion has about 2% prevalence and is commonly seen in elderly patients in 60 years and above. And I usually see this lesion in females, more common than males, and this is also seen in the literature. And considering the classic appearance of the lesion as well as the classic location, you can obviate the need for biopsy to confirm the diagnosis. And this lesion usually appears of soft tissue density with the characteristic linear hypodense strands inside, and these strands represents the fat component, and the enhanced component represent the fibrous component, and hence the name elastofibroma dorsi. This lesion may be unilateral, but commonly it is bilateral, and whenever it is bilateral, it may be symmetric or asymmetric. And the usual history is a female during her path, she felt a lump along the chest wall, and she is worried about being a tumor. Then she consulted one of the physicians who advised to have an imaging modality like CT, for example. Then whenever this lesion is misdiagnosed as a soft tissue tumor, which may be a sarcoma, for example, then the need for biopsy will be resorted to. But whenever you see the classic location of the lesion and the classic appearance and the strands within the lesion, then you know that this is a benign lesion which does not need at all any interventional maneuvers. And here is another example of a elastofibroma dorsi, which is asymmetric. This lesion on the left is more larger than that on the right side. Then soft tissue sarcomas affecting the chest wall are not that common. The fibrosarcoma and fibrocystocytoma are those seen in adult population, while rhabdomyosarcoma, Ewing sarcoma are commonly seen in children. And these lesions have no specific radiological appearance. You just see a mass in the chest wall, and you can reach the diagnosis after you have a biopsy. And this is a female 17 years old with a mass which is centered on the chest wall, partly outside the thorax and partly inside the thoracic cavity. Then, as we will know just a few minutes after, if you see a mass which is centered to the chest wall and you got a feeling that this mass is a malignant lesion, especially in adult population, then the first possibility should be metastatic deposit. But in children, the situation is a little bit different, and the differential diagnosis is more difficult. Then you think of rhabdomyosarcoma or Ewing sarcoma, and also metastatic deposits can be included in the differential diagnosis. Then you have to biopsy this lesion to reach the final diagnosis. And here is the Ewing sarcoma of the rib, and this is the involved rib and is associated by a huge heterogeneously enhanced soft tissue mass with intra and extra abdominal components, as you can see, infiltrating the chest wall muscles. Then this is another example, and in this pediatric, or let's say adolescent age group, the Ewing sarcoma is one of the good possibilities whenever you see a mass destroying the ribs and involving the chest wall from both directions. And here in the plain film, you can see that there is a mass, and you see that the third rib is destroyed. As you can see, the remaining part is not seen in the plain X-ray, and this is the first rib and this is the second rib. Then the CT scan showed the large heterogeneous enhanced soft tissue mass with a sizable intrathoracic component and the smaller extrathoracic component pathologically proved to be Ewing sarcoma. Then this is the lesion which is centered to the sternum, and I used to diagnose such lesions, especially whenever they contain calcium, as chondrosarcomas. And you know that chondrosarcoma is one of the common tumors of the chest wall, affecting the costochondral junction of the ribs as well as the sternum. But this lesion, when biopsied, proved to be malignant fibrous histiocytoma, which is one of the malignant lesions affecting the chest wall. Then primary soft tissue lesions like breast cancer, for example, may invade the chest wall. And you can see here, this is a breast which is involved by carcinoma. You look to the skin thickening, you can see the irregularity, and you can see the mass. But if you look carefully, you can see that this carcinoma has not involved the chest wall. And this lesion has infiltrated the chest wall muscles with no intrathoracic extension. This is a huge breast cancer with invasion of the chest wall muscles as well as the axillary lymph nodes. And you remember that the Bankus tumor is one of the common lesions involving the chest wall. And one of the diagnostic criteria of Bankus tumor is the destruction of the adjacent ribs near the lung apex. And if you see a lesion which is associated with destroyed ribs, the first rib is destroyed and the second rib is also destroyed, then you think of Bankus tumor. And I hope you remember that I have said that whenever you diagnose Bankus tumor from the plain film, then the next modality of choice is MRI for preoperative assessment to see if the lesion is operable or inoperable, because you have to identify the relationship of the tumor to the brachial plexus nerve roots, to the subclavian vein, and to the subclavian artery, and you cannot reach these informations without the MRI, especially the sagittal views. Then you remember that bronchogenic carcinoma, especially the peripherally located tumors, can invade the chest wall and even go outside the thoracic cavity. And you remember that the two most important signs for chest wall invasion are rib destruction and the tumor extension beyond the chest wall. And you see here, this is the tumor, and there is marked tumor extension invading the chest wall. Then you remember that the invasion of the chest wall by bronchogenic carcinoma was previously a contraindication for surgery, but now it is not, since you can remove the tumor as well as the invaded the chest wall en bloc as a single mass. Then if you look here and you see a lesion, and my advice to you is whenever you see an opacity in the lung which is intimately related to the ribs, please look carefully for the adjacent ribs. Then if you see that the rib is destroyed, then you got that this lesion is malignant. And the most common malignant lesion in the lung in an adult to invade the chest wall is the bronchogenic carcinoma. Then you see here the chest wall invasion by mesothelioma. I have mentioned in the pleural lesions that mesothelioma can invade the chest wall and can cross the midline to the opposite side, and it can also extend into the abdomen through the pleuroperitoneal recesses. Then chest wall involving my lymphoma is indistinguishable from metastasis and any other malignant pathologies. But if you know that the patient is known to have lymphoma, then you think that the lesion, or you should diagnose this lesion as a sequelae of the known lymphoma in the patient. Then you see here soft tissue mass surrounding this part of the rib, and this soft tissue mass destroying part of the ribs, and the patient is known to have lymphoma, then you should know that these are lymphomatous lesions. And here is chest wall involvement by lymphoma. This patient had a known non-Hodgkin lymphoma, and you see a huge soft tissue mass infiltrating the anterior part of the chest wall and destroying the adjacent ribs. Then you can see also the presence of some infiltrations in the lung, which may belong to lymphoma or maybe just an inflammatory process. Then you see some pericardial effusion as well as bilateral pleural effusion as well. Then the osseous tumors of the chest wall are not so much different from other bone tumors, and whenever I will talk in the musculoskeletal sector, I will explain in extreme details the bony tumors involving the whole skeleton. But here you know that you have some of the benign and malignant lesions, and metastasis is considered, in my opinion, the most common lesion affecting the chest wall. Then you remember chondrosarcoma, multiple myeloma, fibrous histiocytoma, osteosarcoma, plasmacytoma, and lymphoma. Then some of the benign lesions like aneurysmal bone cyst, giant cell tumor, osteochondroma, eosinophilic granuloma, and fibrous dysplasia. Then the thoracic skeleton neoplasms are uncommon, representing only 5% of all musculoskeletal neoplasms. And rib lesions are usually metastatic, and this metastasis may be from the lung or from the breast. But as I have said, the sternal lesions may represent the chondrosarcoma, especially if they have matrix calcification. Then this is an example of fibrous dysplasia, and you know that fibrous dysplasia is a lung disease in a long bone. It is an expanding lesion with ground glass appearance of the affected bone. Then you can see that this rib is almost involved. The posterior part is totally involved by an expanding lesion showing ground glass configuration, and this is the resected specimen representing the fibrous dysplasia. And this is the appearance of fibrous dysplasia in the CT scan. The rib, the posterior part of the rib on this side is expanded, and you see the cortical thickening. There is no destruction, there is no extraosseous soft tissue components. And this is also a case of fibrous dysplasia affecting the anterior part of one of the ribs. The affected part is expanded and the cortex is irregular, but you can remember that there is no extra osseous soft tissue component, and the extra osseous soft tissue component is one of the criteria of malignancy. Then osteochondroma or cartilage capped exostosis is rare in the chest wall and the spine. And this patient had multiple osteochondromas in the ribs and the scapulae, and you see this classic osteochondroma covered by cartilage in the left scapula, and another one in the right scapula, and you see a third one in this part of the rib. Then chondrosarcoma is a lesion which is well known to affect the chest wall, especially the sternum and the ribs. And you can diagnose the possibility of chondrosarcoma whenever you see a malignant mass containing matrix calcification in a location which can fit for the diagnosis of chondrosarcoma, like the ribs and the sternum, for example. And you see here a mass. How can you know that this mass has a malignant criteria? The two most important diagnostic criteria of malignancy are bone destruction and extraosseous soft tissue components. And there, of course, there are other criteria I will explain in details in the sector of bone tumors. Then this is an chondrosarcoma affecting the rib and part of the spine, a mass with destruction and matrix calcification. Then you assume the possibility of chondrosarcoma. And this is also chondrosarcoma of the posterior aspect of the rib, extraosseous soft tissue component with matrix calcification. This is one of the common and even the most common primary malignancy of the chest wall, and it arises in the regions where cartilage is present, like the costochondral arches and the sternum, and 19% of chondrosarcoma occur in the rib. In the ribs, 10% arise in a pre-existing benign lesion like enchondroma, osteochondroma, chondroblastoma, for example. Then there are two peaks of age below the age of 20 years and above the age of 50 years. And you can see this is a huge chondrosarcoma arising from the anterior chest wall, and you can see the mass and you can see the dense matrix calcification. Then plasmacytoma is an expanding lesion which is the solitary form of myeloma, and it commonly affects the ribs. As you can see, there is expansion of the anterior part of one of the ribs, and this is suggestive of a plasmacytoma. And whenever you have the CT scan, you can realize the appearance of the lesion, and you can see the matrix of the lesion itself, and you can appreciate the degree of cortical breaching, and sometimes you can also appreciate the extraosseous soft tissue component. Then here is a case of plasmacytoma affecting the rib with expansion and extraosseous soft tissue component. You should remember that fibrous dysplasia has no extraosseous soft tissue component. It's a benign lesion and the cortex is intact and no associated extraosseous soft tissue component. But in cases of plasmacytoma, the rib is more or less destroyed, the cortex is breached, and you have an extraosseous soft tissue component. And multiple myeloma is, let's say, difficult to be diagnosed in the plain film unless you can look peripherally in the scapulae, in the clavicles, for small osteolytic lesions in the skeleton. But whenever you have the CT scan, it's an easy diagnosis, especially in the vertebrae and also in the ribs. In the vertebrae, you see first diffuse decreased bone density. And if you look carefully, you can see micro osteolytic lesions infiltrating most of the vertebrae as well as the neural arches. And whenever you see this lesion, you can suggest the possibility of myeloma, and this may be confirmed by biopsy or even by bone scan. And this is one of the classic appearances of multiple myeloma in the skull, where you can see numerous osteolytic lesions with no sclerotic lesions, and the lesions are characteristically of almost equal size. And if you look carefully in the mandible, you can see other lesions, and also you can see in the cervical vertebra. Then the CT scan of the patient may show some of the lesions in the ribs, other lesions in the manubrium sterni, for example, and in the medial edges of the clavicles. And you remember that myeloma in the rib is a malignant lesion with cortical destruction and extraosseous soft tissue component. And this is multiple myeloma of the ribs, and you see the involved ribs with cortical destruction and extraosseous soft tissue components. And osteosarcoma is relatively rare in the chest wall, especially in the ribs, and it presents by an almost totally calcified extraosseous soft tissue mass, which is related to the mother bone, which may be the rib or the sternum or even the vertebra. And this is of bad prognosis than osteosarcoma or chondrosarcoma in the other osteosarcomas anywhere in the body, or in the chest wall chondrosarcoma. Parosteal osteosarcoma, you know that this is a sclerotic lesion which occurs adjacent to the affected bone, is an extraosseous lesion. And this is an example of a densely calcified sclerotic mass which is affecting one of the ribs with a small extraosseous and a larger extrathoracic and a larger intrathoracic components, and this was pathologically proved to be an osteosarcoma. Then chest wall deposits are the most common lesion affecting, malignant lesion affecting the chest wall. And as I have said, whenever you see a mass which is centered on the chest wall, partly intrathoracic, partly extrathoracic, then one of the most likely possibilities is to assume the diagnosis of metastasis. Then this patient is known to have renal cell carcinoma, and of course you should diagnose this massive lesion and the opposite one lesion, as well as the mediastinal lymph nodes to represent metastatic deposits. And this is the classic appearance. If even in the absence of a known history of primary malignancy, whenever you see a mass like this which is centered on the rib and is partly inside and partly outside, then you may think of metastasis. And one may say, why I should not say that this may represent a chondrosarcoma? Well, this is a malignant lesion, and too many possibilities may be included. You can say this is chondrosarcoma, you can say this is lymphoma, and you can say that this is metastasis. But actually, metastasis should be considered the possibility number one, to be followed by other possibilities. And this is an example of a metastatic deposit in the rib. There are equal components of the lesion, intrathoracic and extrathoracic. The affected rib is not seen, and there is no matrix calcification to urge the possibility of chondrosarcoma, for example. Then we will discuss the issue of lymphoma in the sector of the abdominal imaging, but this patient is known to have metastatic melanoma, and the focal lesions in the spleen are metastases, and the lesion in the suprarenal gland is metastasis, and this lymph node is metastatic, and of course the mass in the chest wall and in the axillary lymph nodes are also of metastatic origin. But if you don't know that this patient has metastatic melanoma, we used to diagnose solid focal lesions in the spleen as representative of lymphoma, because lymphoma is considered the most common solid lesion affecting the spleen in adults and even in pediatric age group as well. So we used to look at these lesions as lymphomatous. Then we should consider the suprarenal gland as lymphomatous, and this lymph node is also and the chest wall masses as well. Then this is pleural and rib metastasis. Look here, and you see this pleural lesions encasing the right lung base, almost indistinguishable from the mesothelioma. And here you can see osteolytic lesion in the rib, another osteolytic lesion here, and this represents metastatic disease in the pleura and in the ribs as well. Then finally we came to a conclusion, and we have lesions with characteristic CT appearance. As if you see a hypodense lesion with marginal enhancement, you know that this is an abscess. If you see a hypodense lesion containing fat, and this is lipoma. If the lesion contains fat as well as other soft tissue densities, and you consider liposarcoma. Serpiginous enhancement in the lesion and the calcified fibrobuli is diagnostic of hemangioma or arteriovenous malformation. Destructive lesion with matrix calcification, especially in the sternum or even in the ribs, is diagnostic of chondrosarcoma. Lesion or lesions with pulmonary or hepatic metastasis may be suspected as deposits. Large cystic lesion in the axilla containing fluid is usually suggestive of hygroma. Then if you have a lesion invading the chest wall from the intrathoracic cavity, then you consider the possibility of bronchogenic carcinoma and mesothelioma, and both have characteristic imaging findings. If you have a lesion or lesions with no specific characters nor associated with other lesions, and these lesions are usually solid, not cystic, then you consider the possibility of deposits. And other possibilities that may be included, like myeloma and lymphoma, and in most of these cases you will reach the diagnosis after biopsy. والحمد لله رب العالمين.